Because this disease likes to grow fast, chemotherapy is what's used, whether you have limited disease or extensive. And the chemotherapy probably hasn't changed in 20 years. The standard approach is using a platinum, and that is either cisplatin or carboplatin, and the choice really depends a lot on whether the patient has other, what we call comorbidities, other problems. For instance, cisplatin can have an effect on the kidney. I think that we're very good at delivering this drug nowadays, but still, if someone has some kidney problems, you wouldn't want to give that particular drug. So you might choose the brother drug, carboplatin. So the choice depends upon the patient. The other drug generally that we tend to use is a drug called etoposide. So there's two drugs. They both work differently on the cancer cell, and the two together are better than they are individually. This is basically the treatment of choice in limited disease because these two drugs are easier to combine with radiation. And we'll get to the radiation therapy momentarily. Another combination that we used to use a long time ago and still active is a combination of three drugs called cyclophosphamide, ribosine, pristin. There's still another combination that came from the Japanese, actually, and that's cisplatin and irinotecan. But the latter two combinations of chemotherapy are difficult to give with radiation. So if you were going to use them, you'd be more likely to use them in extensive disease where you don't use the radiation up front. I said that basically nothing has changed much in 20 years. Well, it's not like we haven't been trying. Some of the things that have been tried are using a standard regimen with the addition of a third drug. Unfortunately, that has added to side effects, and the benefits not increased significantly to really make the side effects worthwhile. They've tried alternating combinations. On the previous slide, we saw a platinum and etoposide, and then the second combination was cyclophosphamide, adriamycin, tristin. So they've actually used them in an alternating way because these drugs all work a little differently, but that's not really resulted in any improvement in outcome. They've used other sequences. They've used sequential chemotherapies. They've tried it weekly and tried it to be more intense, and by giving it every week and changing it. That hasn't worked. Because this cancer responds well to chemotherapy, they've even tried high-dose treatment with bone marrow transplant because of the way the tumor responds to chemotherapy, but that also has not worked. So more is not necessarily better. What about radiotherapy? In limited stage disease, it's the standard of care to combine it with chemotherapy, if possible. And it does prolong survival. It's modest, a little over 5% at 2 to 3 years, but it does help control the disease in the chest. If you can give them both together, if you feel the patient can tolerate it, it's better to give both at the same time because they actually work better together than they do individually. As I mentioned before, etoposide and platinum are easier to integrate with radiation because the side effects are quite tolerable if you do that. There's a couple of radiation therapy issues that we've been struggling with over the years. First of all, if you give the radiation, do you give it at the beginning with the chemotherapy, in the middle, or toward the end? And there have been a number of trials, and they're sort of confusing, so I'm not going to show you all those trials, but I think the general consensus is the earlier you initiate the radiation with the chemotherapy, the better off you are. Another question comes up, and that is whether you should give the radiation daily, which is more standard approach, or whether you should be aggressive with the radiation as well. And I'm going to show you a trial that did that by doing what's called hyperfractionation. I have another slide on that, and I'll explain what that is. The other thing is that for years, we also struggled with whether prophylactic cranial radiation was important. It's sort of gone in and out of vogue, but for the last 10, 15 years, we've been doing it routinely. Why give prophylactic cranial radiation? Even though an MRI of the brain might not show any metastases, the brain is a place where cancer cells like to hide, and they can get across, but the chemotherapy that we give may not be reliable in terms of getting across to the brain. We all have a natural barrier between our brain and the rest of our body, and our natural barrier protects us from drugs. The chemotherapy doesn't reliably get across. So often at the end of treatment, particularly, at least in the past, for limited stage disease, we give brain radiation to try to prevent the cancer from coming back in the brain. What is hyperfractionated radiotherapy? With small cell lung cancer, if you look at how the cancer responds, it's called a dose-response curve, a lot of times it will level off, but in the case of small cell, it doesn't. The question comes up, if you gave multiple radiation doses a little bit closer together, would it be better? In some of the trials they've done with giving multiple doses closer together, whether you could reduce some of the side effects to normal tissue, and whether you could actually have better outcome by increasing the cancer cell kill. That's the theoretic background of giving radiation more than once a day. I'm going to show you this trial. It was actually published in the New England Journal of Medicine, now probably 14 years ago. What they did was they gave pretty much standard chemotherapy, and then this was a randomized trial in which patients are computer-picked. Half the patients got radiation once daily, and there's a dose up there, 45 gray, or they got it twice a day. Same dose, but they finished a whole lot early. They finished in 15 days as opposed to taking 25 days by getting it once a day. And they wanted to see if by giving the radiation twice a day they had a better outcome. And actually they did. Now here's the 5-year survival right here. And once daily it was about 16%, but it was 10% better for the twice daily treatment. The side effects were worse. When you give radiation therapy to the chest, one of the structures that really gets affected is the esophagus, and that's your food tube, goes from your mouth to your stomach, and it's sitting right in the middle of what you're radiating. When you give more radiation over a shorter period of time, the incidence of this does go up. But we have a lot of supportive measures that get patients past this. So if you can get past this, which most patients do, they tend to do better. Why do we not do this all the time? A lot of patients don't get hyperfractionated radiotherapy. And the reason is it's inconvenient. You have to give it twice a day. There is more side effects, but as I said, the biggest side effect is esophagitis or inflammation of the esophagus, and we can get most people through that, period. But there's another issue. In that particular study, the total amount of radiation was 45 gray. There is some thought as to whether giving it once a day or giving it twice a day really is equivalent. And that's one of the biggest issues. Now there is a trial that's ongoing as we speak that is looking at radiation schedules to see what is the best schedule to combine with chemotherapy. Hopefully that trial will be completed and we'll have a better answer as to the best way of delivering the radiotherapy. So that's a question we hope to answer. In terms of the prophylactic cranial radiation I mentioned, over 50% of patients will eventually relapse in the brain, about 45% as the first site of relapse. Brain metastases are nasty, so if we could reduce the incidence, it would be important. By giving radiation to the brain, you can reduce the incidence fairly significantly in many of these patients. You can see 67 down to 40% overall, but as a first site, by more than half. There is a survival benefit that has been demonstrated by delivering this prophylactic cranial radiation. We don't know some of the late side effects, but most people tolerate it pretty well. I think one of the bigger side effects I see in some of my patients is that they get fatigued. There are some unanswered questions, and one of them is, what is the best way of giving it? How much should we give? That's still not totally set in stone, although we have a usual dose that we give, but is it the best dose? And when do you give it? We tend to give it at the end of chemotherapy and radiation. And we need to follow patients who get this very closely, so we have an idea of what some of the long-term side effects might be. Chemotherapy, some of it does get across. And if we end up developing better chemotherapy, maybe we will end up not needing the prophylactic cranial radiation as much in the future. But this is a big step. We have to develop better chemotherapy for this to be possible. To summarize, for limited stage disease, and that's patients who have disease limited to the chest, usually one side of the chest, Chemotherapy given with radiation is given with the goal of cure. This platinum-based chemotherapy with early radiotherapy is the way to go. In terms of the other drug I mentioned, the carboplatin, this may be just as good, but we really don't have particularly adequate data. When I give it with radiation, if I think it's safe, I would prefer to give the cisplatin. The chemotherapy, generally for most of the trials, we gave about 4 cycles, but people gave in the range of 4 to 6, depending on how the response to treatment is. Giving the chemotherapy with radiation does improve the survival. Giving the radiation twice a day appears to have a benefit, but is under study. And prophylactic cranial radiation given after the chemoradiation reduces the incidence of brain metastases and improves survival. I usually have to give some numbers so people have an idea of how effective this treatment is. But remember, these are numbers. They are based on large populations of patients, and individual patients are not numbers. So you can't always assume that these numbers fit every particular person. Because this cancer responds very well to treatment, overall response rate, that means at least a 50% reduction in the cancer that you see on scans, is up in the range of 80 to 95%. Complete response, meaning the clearance of all obvious cancer, is about 40%. And the average survival is in the range of 1.5 to 2 years, with, I think, closer to 25% of patients surviving 5 years. I have patients like this. So there is a chance of cure. Let's talk about extensive stage. Unfortunately, about 2/3 of patients present with extensive stage disease. The treatment is combination chemotherapy, and it could be any one of the drugs that I mentioned earlier. It's really the same for extensive and limited. This chemotherapy does prolong survival, and it improves symptoms. So it's very important that we not only increase survival, but make someone feel better. And by reducing the tumor, you do feel better. Usually, we like to use cisplatin or carboplatin-based chemotherapy. There has been a lot of research done over the years, and again, in the last 20 years, not a lot has changed. They've tried using 3 drugs as opposed to 2 with inadequate data. Usually 3 drugs are more side effects with not an improvement in survival. You need the regimen to be tolerable. Maintenance therapy, that is continuing the chemotherapy for a long period of time, has not been valuable. Intensifying the treatment, as I mentioned before, also has not worked. And alternating regimens, using one and another and then just alternating, also there's not been a benefit. So that's what's been done over the years. This is an example of a trial that came out of Japan. You can see the NOTA trial here, and they used platinum and etoposide versus platinum and irinotecan. And they actually saw, at the 2-year point, a better survival for patients who got the platinum and irinotecan. Interestingly enough, when this study was repeated in 2 trials in the United States, there was no difference. Now, why does things like this happen? Well, this trial was done exclusively in Japan. And when you do a trial exclusively in one country that doesn't have a diverse population, you might see differences that you won't see when you do another study in a country that has quite a diverse population like the United States. Nonetheless, both of these are active regimens in extensive stage disease. So that's why sometimes we don't see the same results from study to study. Interestingly enough, chemotherapy is what we do. We can use radiotherapy to treat certain problems. For instance, if you have a patient who has bone metastases that's very painful, or a patient who might have pressure on a nerve or whatever, you can use radiotherapy to treat local areas. I call it spot welding. You treat areas that are a problem. This is in addition to the chemotherapy. For many years, we didn't treat patients with prophylactic cranial radiation with extensive disease. And a trial was done a few years ago and published in the New England Journal about 5 years ago that was surprising. They took patients who had responses to chemotherapy. These were extensive stage patients, and again, this is a randomized trial where the patients got prophylactic cranial radiation versus not. I think all of us expected to see a reduction in brain metastases. which of course was true. But surprisingly, there was also an improvement in survival. So for patients who have a good response to treatment and remain in good shape, prophylactic cranial radiation is fairly routinely used in the treatment of extensive small cell lung cancer to prevent future brain metastases. Unfortunately, the statistics for extensive stage disease are not as good. The overall response rates are very high. The complete response rate is not as good. Survival probably is more in the range of 10 months rather than 8. And unfortunately, we rarely see patients who survive 5 years with this disease. I do see patients who survive 2 years, and I have a few that are beyond, but they are the exception. I have another treatment summary here. Again, limited stage disease, concurrent chemotherapy, and early radiotherapy given together, prophylactic cranial radiation, 5-year survival around 25%, extensive stage disease, combination chemotherapy, radiotherapy as needed, but prophylactic cranial radiation should be considered in patients who do well with the chemotherapy. What about surgery? Surgery is not usually used because small cell lung cancer is considered what we call a systemic disease. However, about 5% of patients or less will present with a solitary lung nodule. And when that happens, this is often in an asymptomatic patient where a chest x-ray done for maybe some other reason picks it up. If there is a single lung nodule and there are no lymph nodes involved, then surgery is used in this particular case, followed by chemotherapy. Surgery has also been studied in limited stage disease after chemoradiation to see if removing any residual abnormalities might help in survival, but the results were inconsistent, so this is not routinely done at this point in time. One of the problems with this disease is that you can get it to shrink, and it can be very dramatic, the results you see within days of getting treatment. But the disease likes to come back, and usually it has some resistance. That's where our problem lies, is that initial treatment is very good, but when the disease returns, subsequent treatment is difficult because we have to find drugs that work. These are a number of drugs that are active in small cell lung cancer, and they all can be used in that second line or third line setting. The drug that's approved by the FDA is a drug called topotecan, and it's not as good as we'd like it to be, but this is the approved drug. Major side effects with this drug are primarily with blood counts. I have used paclitaxel with some success, and gemcitabine, irinotecan. These are all drugs that can be used. I've also retreated with the initial chemotherapy. If the cancer comes back more than 6 months after the original treatment, you can reuse the original chemotherapy, and with some success. However, there's no doubt we need new treatments because the treatment after first-line therapy is really not very good. So in small cell, we continue to look for innovative approaches. One of the approaches has been what's called targeted therapy, where they actually try to study the cancer cell and look for a target that they can develop a drug to attack that target. And that's actually the wave of the future in many cancers, not just lung cancer. Actually, they've been doing it for a while. I can give you an example. Small cell lung cancer can express an abnormality called c-KIT, K-I-T, which is expressed in other tumors, and leukemias, and cancer called GIST. There is a drug for that that's quite effective, but when used in small cell, it didn't work. So just because you identify a target doesn't necessarily mean that's the one that's going to be the key to trying to develop new therapies, but we keep trying. New and better chemotherapy agents are being developed. There's a drug called amrubicin that's been evaluated. It probably isn't better than a lot of the drugs we have, but nonetheless, we keep trying. I think another thing we need to understand is why these cancer cells become so resistant. One of the ways, truly, that we can develop new treatments is when patients participate in clinical trials. I mentioned one trial that's ongoing now looking at the schedule of the radiation is very important. But we have other trials that are actually evaluating new treatments. We have one now that we're involved with in patients with extensive disease, and one of my patients has decided to participate. And there are other trials going around the country. I think this is very important if we're going to develop any new treatments. The other thing I think that we can't neglect is smoking cessation, because this lung cancer is very strongly associated with smoking, and we need to try to prevent it. The way to do it is by having smoking cessation programs and trying to talk to young individuals to keep them from starting before they get into it too much, to try to prevent that from happening. We can reduce the incidence of small cell lung cancer even through smoking cessation.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.